Onc Live Insights is a video editorial program produced by Onc Live.
The treatment of ALL has really been revolutionized over the past few years. And I think it's wonderful to see. We're starting to recognize now that there are subsets of ALL that need to be treated radically different. I think the first that comes to mind in most people's mind is the Philadelphia positive subset. Now, I think if we talked about not integrating a tyrosine kinase inhibitor, be it imatinib, dasatinib, nilotinib, ponatinib, I think they're all being studied in the space, people would look at us as though we were crazy. Why wouldn't you do this? This considerably adds to the benefit. Speaking further, we now understand from a prospective trial presented at the ASH 2015 meeting, that Rituxan is highly beneficial in those with the CD20 positive disease. I absolutely think that as we begin to define more and more molecular subsets, be it the Philadelphia-like subsets, be it the MLL translocated subsets, that we're going to start to, again, define therapeutics that are especially beneficial for these patients. And with that, move the survival forward. That brings me to the not so enthusiastic part of the historical perspective of ALL, and that is we're still batting about 40% long term in terms of what we expect as it relates to overall survival in acute lymphoblastic leukemias. We haven't really beat that benchmark as we've gone from Larson to Linker to ECOG 2993 to Hyper-CVAD. We're still kind of at that same place. Now, the hope is as we integrate Rituxan and these other novel therapeutics into this space, we'll do better. I think the management of the adolescent and young adult is one that deserves special mention. There is certainly data to suggest that we may be able to improve outcomes in that space by intensifying chemotherapy and by including asparaginase from the beginning. I hope that pans out over time. I know that there's data from the MD Anderson group when they tried to compare their outcomes, in this case augmented BFM versus a Hyper-CVAD regimen. They didn't see much of a difference. It was about a 50% long-term event-free and overall survival, which is about what we were getting on the CALGB 10403. Where I'm going with this is we really need to come up with good cooperative group studies where we're randomizing patients across these intensive regimens and asking, who's the winner? I think blindly adopting one strategy and saying this is what we're going to go with may not be the best approach as we move forward into the next decade of therapy. This is what was essentially occurring within the context of the Children's Oncology Group and the Pediatric Oncology Groups. They decided on their backbone, and then you could see incrementally how they built on that backbone and used things like MRD or technologies like MRD to then risk stratify their patients.
The question I'm always often asked, is what is the progress in the treatment of patients with lymphoblastic leukemia? And I think we have to distinguish between pediatric patients and adult patients. Fortunately, the outcome in pediatric patients has improved over the last several years and decades. And later we will talk about some of the improvements with CAR T cells. In adult patients with acute lymphoblastic leukemias, progress has been made in several lines. One is the discovery of cytogenetic and molecular risk stratification, and I will talk to that effect a little later. A big improvement over the last several years was the use of pediatric-inspired cytotoxic regimen in the treatment of younger adults with ALL. Pediatric patients, commonly defined below the age of 18 or 16 years of age, have done better than adult patients, including young adult patients. So several groups, including large cooperative group trials, now tested the more intensive pediatric-inspired regimen in younger adults. Younger is often defined at the age of above the age of 16 to 18 up to the age of 40, and I can talk to that effect where younger, the cutoff for younger or older adult patients is a little later. Those pediatric-inspired protocols have shown that adult patients actually can improve their complete remission rates, as well as the outcome and long-term overall survival and relapse-free survival. So that's one improvement in the treatment of ALL. Another area where improvements have been made and we continue to incorporate it into clinical practice is MRD monitoring, or minimal residual disease. Another area of improvements over the last several years is the development of very specific monoclonal antibodies. And there are several different approaches being used. There are bispecific antibodies, or blinatumomab, recently approved for relapsed ALL. There's antibody drug conjugates that are in clinical development, as well as there are CAR T-cell treatment protocols developed. However, there still remains an unmet need in the treatment of adult patients with ALL. This unmet need is incorporating MRD monitoring systematically into routine clinical practice. Many patients with ALL, adult patients with ALL, unfortunately do relapse, and we need to develop consolidation strategies, which could consist of hematopoietic stem cell transplantation, allogeneic stem cell transplantation, or addressing MRD treatment in patients with complete remission.